Good morning. Welcome to the second day of the conference. I'm going to get us started. We have a great panel of speakers today. So I want to say good morning and welcome you this morning to today's plenary session entitled National Initiatives to Promote Multi-Sector Efforts to Disseminate and Implement Prevention Science, Stories from NIH CEAL and CEAL. My name is Brittany Cooper, and along with my co-chair, Susanna Bart, and the rest of our conference planning subcommittee team, which included Abby Fagan, Ron Prince, and Jacqueline Lloyd, we're thrilled to be here to learn from our esteemed panel of speakers. I also wanted to thank our sponsor for today's plenary, the Southwest Interdisciplinary Research Center at Arizona State University. And so with that said, I'll begin today's session by introducing our three speakers briefly and sharing a brief overview of today's presentations. We're so pleased that Dr. Nathan Stinson, Director of the Division of Scientific Programs at the National Institute on Minority Health and Health Disparities, is joining us today via Zoom. Dr. Stinson will begin the plenary with a discussion of prevention research as an evolving NIH priority in addressing health disparities. He'll set the stage by introducing us to the Helping End Addiction Long-Term, or HEAL initiative, and the Community Engaged Alliance Against COVID-19 Disparities, or CEAL programs, as examples of NIH initiatives to promote multi-sector coordinated efforts to disseminate, implement, and evaluate prevention programming. Next, Dr. Lisa Saldana, who is here with us in Seattle and is senior scientist at the Oregon Social Learning Center, will introduce us to a family-focused program that was adapted for upstream opioid misuse prevention as part of the HEAL initiative. Specifically, she'll be sharing with us the implementation process they used to help facilitate multi-sector partnerships, which provided the infrastructure needed to support program adoption. Finally, Dr. Sarah Brewer is joining us from Colorado and is Assistant Professor of Family Medicine at University of Colorado. She'll describe key components of the Colorado CEAL, which aims to increase COVID-19 vaccine uptake and improve equity in vaccination in 5 Colorado communities. She'll explain again how partnerships, this is a key word you're going to hear over and over again, from the core of the CEAL program and the community translation method, which have been key to crafting messages and strategies that are created by and for these communities. Before I hand it over to Dr. Stinson to get us started, I also wanted to put in a plug for the roundtable discussion that will follow this plenary. If you're excited and energized by this presentation, I really encourage you to join us for the plenary, which will follow, and feel free to ask the speakers questions and continue the dialogue there. That will be in room 302 Beckler at 10:15 a.m. So with that, I will hand it over to Dr. Stinson, who hopefully will magically show up over there.
I certainly hope everyone can actually see my slides. I was hoping to put the video on to say a few opening remarks before I put my slides up, but that's okay. You don't really need to see me. I want to, first of all, just thank the organizers of the meeting for the invitation to come and talk with this group about some of my thoughts related to where I believe NIH is really proceeding with prevention research, not only related to any specific institute, but NIH writ large. I'm coming up on almost 40 years within the Department of Health and Human Services. I started out in the Indian Health Service on the Navajo Reservation, as a clinician, and have worked in several of the different agencies within HHS during my career. And I've seen how priorities have come and gone, over the years. sometimes related to changes in administrations, and sometimes just changes, in the leadership within any particular administration. But every once in a while, due to circumstances, things don't tend to move up and down of priorities, but really move in a certain direction, and a certain direction that I believe moves everything forwards or lifts all boats in a manner of really trying to improve the health and well-being of everyone in the country. And I think we're in one of those periods right now. The difficulty is we never can judge how far we go and how long it lasts, but it's important to take advantage of the circumstances that really have pushed things in a certain direction. I know that Dr. David Murray has given several talks at the meeting so far. He may have even more talks to give to the group about his leadership in the Office of Disease Prevention and their plans of developing an effort across all the institutes at NIH around prevention research. And many years ago, the things that he will assemble, the efforts that he will lead within NIH, to many people probably would have seemed like an impossibility, that NIH is focused so much on bench research and basic biomedical that these other aspects, very important aspects, of health-related research will never get the traction that it really needs, based on the importance of these areas of research in improving individuals' health. But this is where we are. We're at a different circumstance in time. We're at a different point of thinking much more comprehensively about what really needs to be done, to improve health. And from my perspective, real changes require a sustained response. It's like running a marathon, where I've learned that patience is not a virtue, it's a requirement. We all want to get to the ultimate outcome we're interested in as fast as possible. But from my view, as long as we're moving forward, we're not standing still and we're not moving backwards. And I think the real responsibility and burden is really on all of us, including everyone in the audience today, the experts that we need at NIH to help us design and create and implement an overall research strategy around prevention and other aspects that ultimately address some of the health disparities and inequities that we see in health, as a way of really ensuring that the benefits of research supported by NIH is really experienced by everybody. No matter where you live, what your circumstances, or what future directions you see your particular life. So I'm just very, very thankful for the opportunity to have the opportunity to spend a few minutes just giving some of my views on what I think is a very important time for NIH to really push forward a full court press, in prevention, in a way that it has not done before, and will be so impactful out there in communities around the country. So what I really want to focus here is our institute, National Institute of Minority Health and Health Disparities, created a research framework. And we created this framework a few years ago because health disparities or addressing health disparities is a complex problem. There are many aspects to it. There are many elements that are important that influence the ultimate health outcomes that any individual may experience. And so we felt as though complex problems require complex solutions. And so we had discussions, meetings, work groups, our advisory council, all weighed in, on what would some type of framework, really look like, if we really wanted to, to tackle the areas of, health equity and health disparities. I've highlighted this area along the level of influence as being in community for a very specific reason. One of the areas that is become a priority, in discussions around, minority health disparities, research, is trying to advance the knowledge and increase the development of interventions that are acting upon the community as a whole. It's not an effort to diminish any projects, any interventions that are targeted towards, the individual or a certain specific domain, whether it's a healthcare system or, behavioral, changes. It's really to try to emphasize the point that if we're really interested in wholesale changes in these charts that we see around the burden of disease and different individuals and communities around the country, it really is going to require thinking very broadly and designing things very comprehensively. And one of the areas that we think have not had the type of investment in research has to do with community-wide interventions. And so our message to investigators out there, in the academic institutions and other research institutions around the country is depending on what you're interested in and depending on what you're trying to accomplish as far as the outcomes, think very, very, boldly, think very comprehensively, and think about whether or not the project or the program you would like to implement could actually have community-wide impact. Just a couple of things from a definitional point of view, because we run into this all the time about, well, what do you mean by community? What are the particular components in that? And essentially, it's really something that employs community-wide engagement methods, and it really looks at modifying community characteristics. Even though within any particular project, individual characteristics can be modified as well. And it really does try to target community level determinants of health. And many of those have to do with the physical and social environment and policies and practices that are out there. And also, collective, community norms for behavior of members of any particular community. And what it doesn't, constitute is, individuals that exclusively just kind of address, the individual, whether it's helping to manage or cope or even navigate with certain determinants, or ones that really don't target, community level, determinants of health. Now, you probably, are thinking that, there's some gray areas here, and sometimes it's difficult, to separate things out in a nice and clean manner. And ultimately, there's no disagreement with that. And really, I don't think really it's all that important, if things do fall within, a combination of things or within a particular gray area. Our only point is that ultimately what we're interested in is having an impact of individuals, throughout any particular, community. And sometimes that does require thinking about, areas within the community, structure, at large, that could be intervention points that could be very, very beneficial. As was mentioned, I'm going to really talk very, very briefly about two initiatives that, in my mind, represent that type of full court press that NIH has recently invested in, related to issues that, without dispute, are public health, crises or emergencies. The other members, my colleagues on the panel, will give examples within this a program that I think are very illustrative of the great work that investigators like yourself are doing out there in communities around the country. And so I really want to save as much of or give as much as my time to them to be able to really walk you through some really good work and things that I think will be very, very impactful to individuals out there in communities. So the HEAL initiative, which is helping to end addiction long-term, is something that really is focused on understanding and managing and treating pain and improving treatment for opioid misuse and addiction. I don't think there's a need to really talk about this particular issue that in some ways continues to ravage, in many ways, actually is a better word, continues to ravage communities and families and individuals throughout the country. This slide, which I believe all the participants will be able to to get slides of my comments, and I've added links to specific programmatic aspects of the HEAL initiative, so you can click on it and see what specific funding opportunities are available, and also see the current activities, projects that are ongoing under each of these different categories. I'm not really going to spend any time really talking about any of these particular areas, but I did want to give you a sense of the real comprehensive nature of this initiative as a reflection of the deliberate and concerted effort that NIH went through to try to decide where are the areas within this particular domain that would be important to address, because we have the ability to have an impact that will ultimately, if it's successful, as we believe it can be, really change the dynamics, of this, epidemic, throughout the whole country. And so it really has focused on things such as, novel medications, options, actually, new uses for old medications that have already been approved by the FDA, thinking through and testing new strategies to prevent or treat opioid addiction, and making sure that we complete those steps of really translating the research that has been conducted, at the bench, the basic biomedical research, into, practice for, treatment of opioid, addiction. And the other category that they really do go hand in hand is really enhancing pain management, and really making sure that the preclinical work is translated into some very deliberate types of interventions. And also, really the implementation of some, real life pragmatic, trials, in the management of pain to reduce the reliance on opioids for pain management. So I want to just say a few things about the CEAL initiative, which is the Community Engaged Alliance Against COVID-19 Disparities. It has the overarching goals to understand the factors that contributed to the disproportionate burden of COVID in underserved communities, to develop strategies to address misinformation, mistrust, and also to enhance inclusion. And I added the mantra that we have, and I guess it's kind of like a core value where we talk about move at the speed of trust. One of the things that we know has been an issue is researchers going out in communities when they're looking to enroll participants in any particular a trial. And sometimes before that happens, there's been very little engagement by those individuals, those researchers, and sometimes even their institution with the community, at large. And we firmly believe that that things need to be done to build that trust before you even need anything from the community. You just need to be a good community, member. Academic institutions and researchers are not apart from the community. And so one of the things that's always been in the back of our mind as we implement this program is really trying to, ensure that we're doing it in a very deliberate and a respectful way, and that the issues of why we're doing it, why it's important, aren't things that really need to be in the back of the mind of community-based organizations or members of the community. Just very briefly, this initiative was born out of the evidence we all saw, where the burden of COVID-19, both the incidents and also hospitalizations and death, disproportionately affected certain communities, certain individuals who had certain type of jobs, and also individuals who had certain, or lack of certain resources to be able to navigate this particular pandemic. And so in July of 2020 was when the director of NIH really tasked the director of NHLBI and my director at NIMHD to really develop an initiative to make sure testing was available to the communities that were disproportionately affected, and also to try to make sure, as the pharmaceutical companies were starting to implement their clinical trials around, vaccines, that members of these communities had the opportunity to participate if they were interested in participating as much as anybody else. Very, very quickly, I just wanted to indicate that currently we have 21 teams around the country. The ones in the blue were the initial ones, and they kind of matched where the epidemic was, where the pandemic was, particularly devastating at that particular time. And then around a year ago, we added some additional teams looking at some aspects around, where the pandemic is at that point in time, and also what assets the NIH had, as well, as a way of really trying to enable a community-wide effort around, vaccines, testing, and prevention and treatment trials as well. Very, very quickly, in the final few minutes that I want to have, I just want to mention a couple of things that the CEAL has been very successful in, and one is really increasing the diversity of the clinical trials for the pharmaceutical companies who partner with CEAL in the recruitment of individuals into their clinical trials. The racial and ethnic makeup of the participants was much greater in the pharmaceutical companies who did not partner with the CEAL program. The CEAL projects were not recruiters for the trials themselves. We made that very, very clear to the teams, that we didn't want you to go out there and be perceived as an arm of the pharmaceutical company, but you could go out there, as an expert, a knowledge expert, and talk with members in the group, and try to facilitate anyone who was interested in participating to be able to access the particular clinical trials and sign on. Some of the teams have really helped build infrastructure at the local level, at community organizations, through training and other resources that was available. Other teams really focused very specifically on working with their state and community government, as a way of establishing some type of partnership to assuring that testing and ultimately vaccines were readily available to members of the community. And also some of the efforts were around, which continues to this day, in combating misinformation and mistrust out there in communities around the country. The teams have developed a wide variety of different products to really provide to the public. I really want to just take one less than a minute to just show this slide here, which actually is a little dated now, because it's not been updated very recently, to just give you an idea that this is some of the metrics that were assembled around the communications of the CEAL teams, with the community, and the engagement that they had, whether it was through their social media sites or their website, to the degree that you can see that the engagement that they had, the number of individuals that accessed this information or made contact with these teams, was just incredible, and it really reinforced in our mind that there was this real opportunity to use this in a way, in a very broad and comprehensive way, to engage with the community across a wide range of different activities. Again, the slides will just contain some specific areas of engagement of the different the different teams that you can certainly peruse at your leisure. And I really want to really end by focusing on this last slide here, and it really represents some of our thinking when we first started, and first started the implementation of CEAL. And we knew that CEAL was really being supported and developed to really respond to the COVID, pandemic. But we also knew that NIH was making a substantial, multi-million-dollar investment, not just in academic institutions, but in community-based organizations in areas that are not only disproportionately affected by COVID-19, but they're disproportionately affected by diabetes, by heart disease, by suicide, by a lot of things that structurally are representative of what's going on in those communities and what resources those communities have. And so from the beginning, we have always had the hope and the goal that this is something that can be created, and kind of mentioned before, a full court press in these communities, and that we can be able to show the value of doing that. If we do these type of investments in communities disproportionately affected by the disease, we can create a very positive outcomes for the members in that community. So the future opportunity for CEAL is to really use this approach and build upon what we think is a platform to address the broader aspects of health disparities, and to really use the alliance approach to really promote community engagement, and advance health equity in NIH-wide research priorities. So that's our goal, that's our hope, that's our dream, that we really do think that it is very possible. And we see the investigators, the extramural community, especially the ones around prevention, as being keys to really being successful in trying to do that. So I want to thank everyone again for allowing me to share a few minutes, and I look forward to hearing the rest of the presentations that are part of the meeting. Thank you again.
Thank you, Dr. Stinson, for setting the stage. I'm going to hand it over to Dr. Lisa Saldana next, who is going to be sharing her story from HEAL, her HEAL experience. So take it away.
Thank you, Brittany. Good morning, everybody. Thank you. I know that everybody was super excited about seeing colleagues and friends, and so I appreciate that people were able to get up this morning and come here, but now I can't work this. How do I, it's not going in. Oh, there we go. Okay, perfect. All right. So I'm going to be speaking with you guys today about a HEAL project that we have going on. And I'm just going to apologize in advance to any of my HEAL colleagues in the room. You guys might have seen some of these slides before. But what I'm going to be doing is I'm going to be describing on the outset a model that we had. I'm going to go through it really quickly, a prevention model, and then how it is that we adapted it further for prevention, for upstream prevention, and then involved it in the HEAL. There's a lot of community involvement here, which is why I'm really excited to talk about this with you guys this morning. To start off with, I just want to thank my team. My team is so great, and seriously, they're the ones that are doing all of this hard work. In particular, I want to point out Gracelyn Cruden, who is here today and has been instrumental in getting particularly the prevention adaptations done for this project. So just to set the stage, this is a project that falls within the HEAL prevention initiative. And so part of that initiative was that we were really focused, or NIH came out with a strong emphasis on wanting to develop and evaluate preventive interventions to prevent the escalation. So either the initiation or escalation of opioid and then methamphetamine, which is what I do, use disorder, but really targeting the age range of 16 to 30. So to orient you to our project just very, very quickly, this was a 2-phase project. So it was a GH. And so the G phase, which we did in the first year, that's really where we were looking at building community partnerships, identifying where it was in our community within our state that we were going to target, and then actually doing the adaptations for our particular program. We are now currently in the H phase. We're the second year into the H phase of this project. And so I'm going to share with you where we are right now, including some of the challenges that we've had, because I think the challenges that we have really speak to some of the challenges of bringing prevention into community settings. So the beginning, like I said, was just to develop the strategies. But then in the H phase is where we're testing the effectiveness of FAIR. And I'll explain to you what FAIR is in just a second. To again, prevent, we're working specifically with DHS involved families. So families that are either involved with or at risk for involvement with the child welfare system. We want to examine this as a hybrid trial. And so we're looking at both clinical effectiveness, but then also implementation outcomes. And then we want to assess the cost associated with this as we start to develop sustainment plans for wide and broader scale up. So to begin with, though, what is FAIR? You're going to hear me talk for the next 20 minutes or so about FAIR as being an intensive substance use, mental health parenting program. But at its core, at its essence, really what it is it's a preventive intervention that was developed to prevent child placement and to try and help facilitate child reunification for families that are involved in the child welfare system. So I know that some folks have heard me say this before, describe this slide, but I think it's important to set the stage. So this all started as part of a NIDA K award that I received. And at that point in time, I knew that I wanted to do a preventive intervention with child welfare involved families, but really went to the system themselves to try and figure out what were their pain points, where was it that they were needing assistance. And no matter where I went around the country, I did qualitative interviews. I also did focus groups. No matter where I went, all of the system leaders, as well as the families I was speaking to, they all kept coming back around to this intractable problem between the cycle of substance use, parental substance use, and child neglect. So looking to the literature to that, not surprising to, I think, prevention scientists here in the room, what we found is that there were a whole bunch of shared social determinants of health that really were driving that child neglect and that substance use. So for families that were experiencing this and for children that were experiencing it, there's like a double shot at this, right? And then what ends up happening is that here on the left-hand side, this is where we see these cyclical natures that happen within families. What we know on the right-hand side is that when we talk to systems and we talk to other providers, everybody sort of agrees that there's the standard set of requirements for families to move through the system. They include treatment, including substance use, mental health, parenting treatment, a lot of social needs. So of course, wanting safe and stable housing, employment, education, but then also a bunch of legal needs. These are families, a lot of families who I myself would have a really difficult time navigating some of the legal challenges that they're faced with. So everybody sort of agreed that if we can get families to receive this set of services, well, then we're more likely to achieve our proximal outcomes, so our positive individual family outcomes, but then also those system desired outcomes, the distal level outcomes. So looking at, like increased reunification, family preservation, decreased days in care, things like that. The gap, though, the barrier is that there's nothing right now. A lot of families, they really experience the barriers moving from this left-hand side of the slide over to the right-hand side of the slide. And so that is where FAIR comes in. I want to be very clear. FAIR is not just a service access. It's not like a navigation system or program where we're just moving people into other services. Instead, what we did is we wanted to really develop sort of a one-stop shop. How can we make it easy for families to be able to access this whole constellation of evidence-based services, but in a way in which they were going to be able to access it, in which it was going to fit within their families, within their environments, within the communities with which they were living. So that is FAIR. So FAIR then ends up being a 4-component, equal component, integrative model. It's ecologically focused. So I think a lot of folks in the room are familiar with some of the well-known evidence-based practices for treatment. For instance, MST. So I grew up in the MST world as a graduate student. My first job was there with MST. And so sort of this intensive going out into the homes, that was something that's sort of the way that I grew up. And so that just seemed like a natural fit when I was developing an intervention where we're trying to be barrier busters and break those things down. And so one of the things that we realized, though, is that engagement was going to be key. And so we view engagement, and actually are studying right now, engagement as being one of our mechanisms of action for our programs. So all of this, and part of that is because the families we work with, when we work with them, it's like what is inviting and engaging to them on day one, that's not necessarily what's going to be inviting and engaging to them like 3-4 months later as they've evolved throughout their treatment. So for us, we are looking every single day, every single session. One of the things that our providers do is look at their engagement efforts. So just very, very quickly to take you through the model so that we can get to the good stuff about HEAL. Is that so for substance use, when we're treating substance use, we rely on a version of a contingency management system that we've been able to establish, not using vouchers, but instead using donated goods so that we can make it sustainable. And then a range of other tools that we've developed specifically for our program. For parenting, I'm an OSLC, and so not surprisingly, we rely a lot on PMTO, Parent Management Training Oregon. What we've done is we've made some modifications to some of those core components to the model to also include things that are more specific to neglect. And so looking at things like nutrition, looking at attachment, looking at educational neglect, things like that to really help support families and parents. And then on the mental health side, we rely more on cognitive behavioral strategies, but we are a behaviorally focused model. And so we use all of our behavioral strategies in order to help families engage in those cognitive behavioral techniques. We really focus on the here and now. We view FAIR as being something where we are referred families that are a lot of times they're in crisis when they come to us. Our goal is to work with them over the course of approximately 8 to 9 months to achieve stability. But we know that the families, the histories that our families come with, there's a long road that they might have in order to address a lot of their symptoms if they so choose. For us, we are trying to reach them to get them to a point of stability so that then they are able to access those other services. And then ancillary needs. Ancillary needs is something that we developed or came out of our original pilot project. And this really are those social determinants of health that we've been talking a lot about the last day. So these are things like housing, getting nutritional food, some basic documentation. And in order to be employed, you have to have your social security card or some form of ID. And so really helping families to be able to access those needs. So the engagement strategies that we use, one of the things that we say, and I think in a session that we were in yesterday, I was talking about the value of making whatever it is that we are doing in treatment more reinforcing than what it is that we're competing against. And in this case, we're competing against opioid and methamphetamine use. And so what are the sorts of things that we can do to help make the time that they're spending with us more reinforcing than what we know to be your very significant reinforcing drugs? So part of it is that we we meet and we get to know our clients and families in the communities in which they exist. A lot of our population, over 60% of them at any point in time, are unhoused. So this means that we're going out into camps, we're meeting families there, we're meeting the communities that have been built in those camps. A lot of times we might be going to family members, people who are doing couch surfing. But regardless, this requires flexible scheduling, non-traditional treatment sessions. We're always showing up with a cup of coffee or perhaps a half a sandwich. As I say when I'm training folks, it's really hard to get our clients to pay attention and to sort of like attend to what we want to in treatment if you're hungry, if all you're thinking about is how hungry you are. So we try and address those things as part of our everyday treatment sessions. And then one of the things, as I said, is we never stop engaging. We use what's called fair bucks as our part of our incentive program for that contingency management bit. And so everything that you do in treatment, we are very heavy and liberal with the fair bucks. And so, you tried a new parenting component, you get a fair buck. You have a clean or a negative UA, you get a fair buck. And those fair bucks then get to be spent at the fair store. I don't have time to go into the fair store, but the fair store is a store of magic. This is where we really have worked hard with our community partners to be able to identify what are the needs of the families that we have. And there's a lot of different weight-ranging needs. Some are kid needs, some are individual parent needs, some are family needs for keeping households safe and clean. So household goods, laundry detergents, but then also things like clothing. Maybe somebody has a job interview, and so being able to dress nice for your job interview. All of those things are built with our community partnerships. We have a resource builder who goes out and builds those partnerships. And that is how we have been able to do a contingency management system in an area where Medicaid has not been paying for contingency management. Oops. And then key and essential is our partnerships with DHS, so with the Department of Human Services and the criminal justice system. We view them as treatment partners. We make it very clear to the families we're working with. We are working alongside DHS, though. We are not a part of DHS. And part of that is it's essential for us to be able to work with one another, but to also respect that we have very different roles, responsibilities, and the way in which we are interacting with our families. Because we set that on the outset with our community partners, we actually don't have very much challenge with that anymore. That was a lesson learned, though. That is not the way I did the pilot. So it's much more smooth running now. So after we were done with some of our initial trials that were funded by NIDA and ACS, and actually this was by NIDA, our local child welfare system asked us if we would continue to provide the service in the community. It was something that they didn't want to have taken away. We are now providing a service for these families that have been really challenging to engage in evidence-based services. So in 2015, myself and some colleagues, we founded a clinic as part of our organization. And that is a clinic where we then started offering FARE as just a regular service to the community. So we serve all of the county. And again, we are going out. It's an outward facing where it's a community based. Folks don't come into us at the clinic. We're going to them. This then allowed us to then conduct an effectiveness trial. And so ACS supported us where we were able to now, and our original trials also were only with moms. However, we've been serving dads in our clinic. And so our effectiveness trial also allowed us to be able to look at the difference or the similarities between moms and dads. We conducted a dynamic waitlisted design and were able to follow folks for 24 months. Our eligibility criteria is pretty straightforward, and I want to move through this quickly. But basically, we are only serving folks if they are on Medicaid. We are a Medicaid-only clinic. We need to have a child, any child between the ages of 0 and 18. So indeed, we do, in fact, work with moms who are pregnant. But then there needs to be a reunification plan in place, or at least a chance of reunification. So our final sample for this original effectiveness trial was 99. And our general results where we had very high engagement, much higher engagement than what we see for other services. You see that our retention dropped down to 72%. However, that is still much higher than what we see from other community substance use, parenting, and mental health programs. At 24 months, our effectiveness outcomes were outstanding. And again, I really attribute this to the team. We're just the ones analyzing the data and writing it up, but our clinical teams and that we've been working with are really, really phenomenal. And so what we've seen is we've seen reductions in, those substance use targets, in mental health issues, but then improvements in parenting and improvements in some of those social determinants of health, including days employed and housing. So I'll show you just real quickly. So these are odds, but this is, so basically what we see is that about at the 8-month mark, this is for our methamphetamine and opioid use, we've dropped down significantly. And then we follow these families to 24 months, and we see that we're able to sustain those gains out through 24 months. These graphs here, what I wanted to show is the fact that and this is in our publication, but to show the interrelation and how our different outcomes sort of relate to one another. And so again, we are targeting all 4 quadrants for FAIR. And what we see is that as methamphetamine use is going down, we actually see a little increase in depression for a bit. This is something that we see consistently. We've seen this pattern of behavior over and over again. So it's a real thing. It's not surprising, right? So we've stopped using, we've taken away the drugs. Now we're feeling all of our emotions. We're also recognizing some of the challenges that we have to overcome. And so we get a little bit of a blip in depression, but then it drops back down, and it drops down to manageable levels. We have decreases in child neglect behaviors, but then we start to see increases in, what do I have here? Days employed. And so this is full-time employment. And so we see increases in full-time employment. That last one for employment actually only becomes statistically significant at that 24-month mark. Actually, I think it's the 16-month mark. So it takes some time for us to be able to achieve stability before we start seeing those outcomes and those social determinants of health. So we had the good fortune of being represented in the TSBM. For folks that have not been able to see this, I encourage you to do this. This is Doug Luke and colleagues at WashU. And this is a way to really look at different interventions and preventive interventions to see the impact, the public health impact that they have. And so in this analysis, we were able to see that FAIR was able to achieve a clinical, a community, an economic, and a potential policy health impact. Former FAIR clients, they're the ones we've started to really, like I said, FAIR's been around now since 2015. So we've served over 1,000 families in the Lane County community. And a lot of those families, it really is coming from word of mouth. And so we have families that are saying, that they're getting more out of the program than they expected. The flexibility is such that they are able to achieve more goals than what they had expected. And now I'm realizing I've got to really talk fast. So sorry. So I'm going to hop on over then to the HEAL project and what it is that we've been doing with FAIR. And so FAIR, for HEAL, what we've done is we've wanted to make adaptations to say, could we take FAIR upstream now? So we know that we are getting positive outcomes when it's coming to preventing. Again, we wanted to prevent children going into care, and we want to increase rates of reunification, decreasing parental substance use, mental health symptoms, and increasing their parenting supports. But now, if we didn't focus so much on the opioids and methamphetamine, could we still use all of these strategies to prevent parental opioid and methamphetamine use disorders? So Gracelyn, who is here with us today, Gracelyn Cruden, she used some of her fancy system science and methods to be able to help us really understand. She interviewed previous and former FAIR clinicians, as well as previous and former FAIR clients, to be able to understand what was it that helped them to engage in the program, and where did they see the biggest benefits. And what we were looking for is if we took the substance use component out of it, what would be left? Well, what was left still was all of the other things, right? What we found really is that it is addressing those social determinants of health, that we are showing up, that we are bringing things so that they are able to engage in treatment. That is really what it was. That's sort of the secret sauce of what they were targeting. So where we ended up doing is we thought we were going to be making a lot more adaptations, but really the difference between FAIR and pre-FAIR is the level of the frequency in which we're meeting folks the level of intensity where we're addressing the substance use disorders. And then also this happened, as you all know, with COVID. And so that gave us also the opportunity to be able to test and see, would we be able to deliver this lighter touch intervention using virtual methods? And the answer to that is yes. So how did we select where we were going to go into our communities? Well, we did this in partnership with DHS. So at the state level, we worked together. We merged our Medicaid data. We merged DHS data, our child welfare data, self-sufficiency data, which is like housing programs, TANF, those sorts of programs. So all of this data, these administrative data, we worked with the Oregon office that does all of these sorts of analyses. And what they were able to do is they were able to identify the regions in which they would most benefit from prevention. And so they identified 5 different counties. The yellow star there is where we already exist. So that is the county that we are already in. But we identified other 5 different potential counties that we might be able to go into. Ultimately landed on District 4. The reason why we landed on here is because not only was this an area in which there was an identified need, because there were, all of these factors sort of pointed to those areas, but also there were no services. And so we wanted to go into areas where there actually was a need, because there were not mental health services, or there were not substance use services to help those families that were going, skyrocketing into the child welfare system. So we actually ended up developing 2 different clinics throughout this district to be able to serve all 3 counties. In order to do that, we had different level of the county level partnerships. So that includes, as I just mentioned, Oregon Department of Human Services, but also a lot of partnering. A lot of time was spent with our Medicaid our Medicaid brokers to be able to get that funded in each of these different counties. We are a county-driven system, and so not a state-driven system. That means that we had to broker it with all these different Medicaid providers. Then our community providers, we had to develop relationships with providers. And what we ended up doing is selecting one existing treatment center where we helped them de-adopt their previous non-evidence-based practices to then implement our evidence-based practice. But then in the other clinic, it was a brand new clinic. In another region, they had 0 clinics. And so we helped to build that clinic from the ground up. And then also working with caseworkers and attorneys. I'm going to really go fast. And so now then we follow what is called the stages of implementation completion. And so some folks might be familiar with this, but this is something that other members of my team and I have worked on together. And it's a standardized way of operationalizing the implementation process. So we developed a SIC for FAIR, implementing FAIR. And just to make sure that you guys understand that after every single one of these SIC activities, so a funding plan review, if you drill down, there are a number of different things that we need to be able to do to implement those strategies well. So this ended us up. So we had our Newport clinic here on the coast, and then our second clinic, which is in Albany. However, we did the typical sort of implementation strategies at the provider level that I think folks are familiar with. So we're doing our on-site training. We do group supervision that is recorded every week. They receive fidelity scores on that. And then the supervisor is receiving one-on-one coaching. We help them build out their FAIR store. And we have a fidelity monitoring system called FIDO. So then that's the county where we originally had thought that we were going to go. However, one of the other counties, Douglas County, through Community Drive, their desire, they were like, well, we want to do this too. We need this in our community, and we're hearing about the success in these other communities. And so Jessica Hunter, who's going to be joining me for the roundtable session, I hope you guys can join us, from District 4. She and her group really helped us to be able, we found foundation funding from that county, and then we have now started 2 clinics in that county. It's a very rural county that only had 1 existing treatment center for that entire county. So that then leads us to now we don't just have our 2 clinics here. We expanded our clinic in Eugene, Oregon, and then we have our 2 clinics there. And all of this, though, is happening in the context of Oregon's opioid epidemic, which is really, really going out of control. So since the COVID-19 epidemic started, or pandemic started rather, we have seen a surge. Oregon has always been known for its substance use, and that has really taken off in the last couple of years. And so we're seeing lots of overdose deaths. We're now ranking really high in terms of, both methamphetamine. Before we weren't seeing overdose deaths with methamphetamine, but now we are because of the combination of meth and fentanyl. But what we are is we also are last in the nation for treatment services. And so this has really provided an opportunity for us to be able to help those clinics. And I'm sorry, Brittany, I'm going to speed through this really quickly, but and so what that though has really led us to is the challenge of our communities are in need of treatment. And here we are trying to provide for them this upstream prevention. Part of the challenge too is that we've developed these clinics that are supposed to be, we want to create these sustainable clinics. We want to have these services available in the community. And so these agencies rely on reimbursement. So if people are not referring prevention, then those clinics are going to go under again. And so what we decided to do is so we're trying to do our upstream prevention, but in order to get to our upstream prevention, we're going downstream. And so what we've done is we've been offering services for our downstream prevention program in effort to spread the word and to embed ourselves within these communities so that we then can go back at it for our upstream. And what we have found is that is actually starting to work out. So just real quickly, in order to be in, to get in the program, you need to be, have Medicaid, have a child in the home or a reunification plan in place, be for pre-fair, used methamphetamine or opioids 3 or fewer times in the last 12 months, and then again, fit within this age range that NIDA is interested in. What we find here, though, is that you see that the vast majority of referrals that we've been getting have been for the treatment. And so we actually have screened as many clients as we said that we were going to for, so we've been successful in getting the numbers, but not successful in getting the actual population. We are, however, if we think about all of these families that we are treating now and that are now available to be treated because of HEAL and our more downstream prevention, these families, we are starting to see huge differences. Because they are not our original target, we don't have a bunch of outcome measures on them. But just real quickly, just so that folks can see, is at the individual level, we're seeing what we would expect from FAIR in terms of those reductions in substance use, mental health problems, and increases in stability. At the child and family level, we're seeing reunifications, and we've seen a lot of cases in these counties, in these rural communities that didn't have services before. It hasn't taken much for child welfare to be able to go ahead and change reunification plans. Kids that were on the track to adoption, those plans have now been changed back to return home. And before, that was pretty unheard of for us. We're seeing system level impacts. The court systems have changed in these counties, have changed the way they are having requirements for families so that participation in FAIR means that they will be meeting their court requirements. That's again a secondary consequence we never thought that we were going to be able to have. And then we are also being invited to other community, community tables. So we are advisors for the System of Care Advisory Board, et cetera. And then of course, those ongoing community partnerships that we're looking at. So we are seeing incredible program outcomes, right? We're seeing clients, we are obtaining reimbursement. One of our clinics broke even for the first time this year, which is really great. In less than 12 months, they were able to do that. So from an implementation standpoint, again, it's a hybrid trial. Total, I would say I'm very happy with that. When it comes to evaluating the effectiveness of pre-FAIR as a upstream prevention model, though, the jury is still very much out. So in sum, I just want to say thank you very much to HEAL, because HEAL has allowed us the platform to be able to see and learn a lot about implementing this complex intervention in communities, really embedding this within the communities, and then really helping us to see how important those community partnerships are, because again, the communities now are taking them on their own. Those HEAL sites, those are not our sites. We do not own those. Those communities own them. They are continuing to see their referrals. And you can see, you saw on that graph that the number of referrals for prevention are starting to finally go back up. So thank you. I just want to thank my key partners at the Oregon, at the provider and Medicaid level. And then thank you. We have the roundtable after this. And I just wanted to point out that this is where the person who'll be joining me is from. Jessica Hunter is from that additional county. So thank you.
Thank you so much. So again, we're going to go back to our magical screen over here. Hopefully Dr. Sarah Brewer will be showing up soon to conclude our presentation today and share a little bit more about her CEAL program in Colorado.
Hi, everybody. I hope that's working on your end. Like Dr. Stinson, I was hoping to be able to come on video and say hi, but I'll go ahead and dive in since we only have a few more minutes. So I am going to talk about our Colorado CEAL program, and I'm going to emphasize now that we are in much earlier stages than Dr. Saldana's HEAL program. We were funded almost exactly a year ago to start building up this infrastructure to address COVID-19 in communities that were really experiencing disparity. And I'm going to focus a lot on our partnership building and some of our very initial work with these communities in Colorado. So I'm going to start by sort of giving an overview of what we're doing in Colorado, what our approach is, introduce you to some of our communities and partnerships. And then I'm going to start with what we learned at baseline from working with these communities, so that you can understand what we're really trying to address, what some of the attitudes and challenges in these communities that we're trying to really face head on in partnership with our communities through this model called community translation. So I'm going to start with our Colorado CEAL overview. So the Community Engagement Alliance Against COVID-19 Disparities, our mission is really to provide trustworthy information through active community engagement and outreach to people hardest hit by the COVID-19 pandemic. So these were largely defined by sort of urban versus rural communities and by racial and ethnic communities that were really facing much worse outcomes from the COVID-19 pandemic. And we're doing that through long-lasting partnerships that are really improving diversity and inclusion in our research and in our COVID-19 response more broadly. So our first big objective in Colorado was to conduct urgent community-engaged research and outreach that focused on COVID-19 awareness and education with a really strong emphasis on COVID-19 vaccination. And then second, we are also working to promote and facilitate inclusion of diverse racial and ethnic populations in clinical trials. I'm going to focus less on that second objective today. We're going to focus a lot on our vaccination initiatives. So those vaccination initiatives, we have really approached this with two big activities. The first is 2 rounds of community, or formerly boot camp, translation in each of our communities that create messages and materials and community dissemination activities around COVID-19 vaccination. And I'm going to explain that community translation model in a minute. But those 2 rounds are focused, we did one in the fall of this last year and are wrapping up our second round now and moving into community dissemination. And this is a point where I really want to harken back to what Dr. Stinson said in his portion about moving at the speed of trust. If we had gone with our original plans, we would have had 2 rounds done by December, and we would have had all 3 of these surveys out in the field. But we moved at the speed of trust, and we slowed down and we changed direction when our community partners told us that things were not working or that things required more relationship building before we could move forward. And so what I'm sharing today is really the results of that trust building that we did with our community partners in the early months of this first year. we approached all of this with a huge university team. So this is just the team we have at the university. In a few minutes, I'll share all the other people who are involved, but you can see that this work doesn't happen with one investigator at a university. Our research teams are as diverse as the communities we're working with, in the sense that it requires expertise from all different sides of the work that we're doing. So let's move into our communities. So Colorado, we are focused on 5 different communities that are experiencing COVID-19 disparities. And when we originally conceived this, that was really based on case rates, because that's where we were when this was being developed. But you can see we have a very strong focus here in the Denver metro area. We are working with Latino, Latinx, and Hispanic communities in the Denver metro area and in Pueblo, which is one of our smaller urban areas in Colorado. We're working with our Black and African American communities in the Denver metro area. We're also working with American Indian Alaska Natives in the metro area. Then we also have 2 larger rural focuses. The first is our Black and Somali immigrant community in Weldon, Morgan County in Northeast Colorado. And then our Latinx Hispanic community down in central southern Colorado in the San Luis Valley. So you can see we're pretty geographically spread in the work that we're trying to do with CEAL. And then we also have, we started this work with a network of community organization partners. So clinical partners, nonprofit service providers, local and state public health, and advocacy organizations with grass-top networks who were already starting to address some of these equity issues with the pandemic. So we brought all these players to the table to think about how can we improve some of our grassroots and grass-tops connections to really engage community members, not just in service provision, but in developing interventions that are going to work for these communities. And then, so we took that university and those community partnerships, and we went further, and we really partnered with influential community members to build trust and strive to meet each community's unique needs and to reach members of those communities who we otherwise would have no way to connect with, because we don't live and work in the communities that we were working with. So our model for this was to hire people we called community connectors. So these are people who are really gatekeepers in communities. They know people, they are trusted by communities, and we hired them to act as sort of consultants and liaisons to the project. They were team leaders in their communities, so they recruited and managed data collectors, as well as community translation participants. And again, I'll explain that community translation model in a few minutes. And then to manage some of the activities on the ground in their community. So they were the face of our CEAL project in their community. And then we also hired, like I said, data collectors in each community who were tasked with recruiting longitudinal survey cohorts of 100 to 200 people in their community and to administer those surveys. And the advantage of this really is they are the face of the CEAL project to individual participants. And they have also a community connector they trust. So community members are seeing the same face come back again, somebody they know and trust. And these community data collectors have a leader that they trust in their community who is working with our university team. So you can see we've got these 5 communities we're working with, and we have teams of people working in each of these places. Our community connectors, our community translation facilitators, our data collectors, and there are many of them, so they're not all listed by name here. But this takes a lot of people to do this work really well in order to build this sort of bridge from our university team with our community organizations, our grassroots and grass-top partners, to eventually lead to that sort of individual community change and really with a focus on capacity building over time. So let's dive into more of the COVID-19 pieces here. So we started this project with trying to understand what was going on in these communities, what were people thinking about COVID-19 vaccination in particular, but COVID-19 prevention more broadly. So I'm going to share some preliminary results from our wave 1, our baseline survey. Wave 2 is in progress, and we'll conduct a wave 3 later in the year. And before I dive into them, I just want to share, despite all of our efforts in community, engaging community members and building these sort of hub and spoke teams in each community, there are still challenges with collecting this kind of data. One is that we collected data in multiple modalities, and in some ways that is a huge advantage, but it also meant that rather than having sort of direct data entry from each survey administration, we might have paper for some, we might have them directly entered online, we might have them on an iPad. And so really bringing those all together and making sure we've got a really clean data set. We have teams all over the state. You saw that map. So we have data collectors in various places all over the state, and even those who have a community connector who's somebody they trust, they may be 2 counties over if they're in that San Luis Valley region, for example. Technology, so our original plan was to collect all this data directly into the RedCap app, but we had a number of issues with that, including that not all of our areas have really strong broadband cellular data access. And so that was not always a feasible way for everybody to enter the data that they were collecting. And then just in the context of the world we're in now, recruiting and retaining staff to do things like data entry and cleaning caused a lot of delays in making sure that we could be really responsive to our communities. So we are getting around that in many ways, but thinking about some of these challenges as we dive into this data. So a little bit about this, I'll orient you real quick. This is our overall sort of sample for our baseline survey, and then broken out by 4 of our 5 communities. Our American Indian, Alaska Native are excluded here because of some of those delays. But a few things to point out, most of our participants did end up responding in English, but we did have a portion in Spanish and Somali. Our average age of participant was 41.8 years. We do have more female respondents, and 60% of our sample did not have a higher education degree. So we have 20% with less than a high school degree, and 40% who are high school graduates, and then about 30% with a degree beyond that. And then about 62% of our sample are employed. And you'll see a few differences here. For example, we have more males in our Somali rural Black community, slightly older group for our urban Latino group, and more educated. And then our rural San Luis Valley group was more likely to have children in the household. All right. So what did we learn? We learned that on the whole, a lot of our community members are doing prevention behaviors around COVID-19. But some of these aren't as high as we might have liked, especially thinking about this being collected last fall as we were moving into some of the Omicron wave for COVID. So still seeing about half of our group always wearing a mask or distancing when that's appropriate. When we break this down by community, we can see that those are a little bit lower masking and distancing in our Latinx communities, and significantly higher hand washing, masking, and distancing in our rural Black communities. So what kind of information are they trusting? So how might we understand where we can share information, who can share that information? So providers in public health were really our most trusted sources of information across the board. But still, about a third to a half of respondents didn't trust those sources a great deal. They might have trusted them somewhat, but really thinking about who is and isn't trusted for providing information. when we break this down by community, we can see that those are providers in public health are still really high. There are a couple key differences though. Our urban Black communities really trust their family, friends, and faith leaders. And our state and local public health are strong, but less trusted in some of our communities. So things for us to know and keep in mind as we move toward intervention development. So we also asked about vaccination behaviors leading up to our work. So you can see Colorado's overall vaccination rate. You can see all of our communities are below that for having received a single dose, and particularly lower in our urban Black community. Our rural Black community was still pretty low. And then having a completed course, again, we see these lower rates. Only our urban Latinx community had reached the overall state vaccination rate. And then what we saw was also that most who get one dose are completing the full course. So these numbers are not significantly lower than the one dose rates. For those who hadn't completed, we saw relatively low intention to get a COVID-19 vaccine in the next few months. So most of these were pretty low. Our rural Black community was more likely to say they intended to. Oops, sorry. And then for getting a booster, so this data was collected as boosters were being recommended, but we saw really high levels of intention to get a booster vaccine if they had completed the primary vaccine dose. People who got the vaccine said that they did it to keep themselves, their families, and their communities safe. And those who hadn't had concerns. So they were concerned about side effects. They didn't trust that the vaccine would be safe, or they didn't know enough about how it worked to trust the vaccine. So you can see levels here of those concerns. But what we also saw was that some of those were unique across communities. So you can see these first couple were really common across all of our communities, but you can see in our urban Latinx community had more concerns about infertility. Our urban Black community had more concerns around fetal cells, changing DNA, or religious reasons. And our rural Black community was concerned about needles. We also, in preparation for childhood vaccination to be recommended, asked what people intended to do, what they had done for their teens and what they intended to do for younger children. So we see that much lower percentages of people who had children in these age groups had their children vaccinated. And again, lower percentages had intention to vaccinate their younger children. So these are things we were trying to think about how to address with our communities. Same 3 reasons for getting children vaccinated for those who intended to do so or already had. They wanted to keep their family, their children, and their community safe. And very similar reasons for not vaccinating, although at higher numbers. So concerns about side effects, not knowing enough about how it works, and not knowing if it's safe. And again, a few unique things in these communities. So our urban Latinx communities were concerned about containing fetal cells causing infertility or effects on children's school performance. And then our rural Black community, again, was concerned about needles, but also about getting sick, or not concerned about their children getting sick from COVID-19. So all of this helped us to understand what we might need to do with our communities to promote COVID-19 vaccination. And we did that through a process called community translation. So what's community translation, formerly known as bootcamp translation? This is a process of community engagement for developing messages with communities that can really resonate with those communities. It was developed in the High Plains Research Network, which is in Eastern Colorado, and used to be really a 6 to 9 month process with a combination of conference calls and in-person meetings. They're really focused on what do we need to tell our community, who in our community needs to know it, and how are we going to communicate it to them, and then develop distribution plans or dissemination plans for getting those messages out. it worked really well, but so why would we mess with that process? We needed to adapt though. So our information needed to reach the communities more quickly. COVID-19 evidence was becoming available and changing quickly. We needed to potentially have more than one campaign at a time within this broader topic of COVID-19 and vaccination. We couldn't at the time do face-to-face meetings with our community members. And our communities really expressed to us a distrust of the university as an institution and a need for our facilitators to be more culturally humble and to have insiders or community members as facilitators. So we made a number of adaptations to make this work. We made our meetings more frequent, virtual, and had fewer meetings overall. We moved some of our key components to online. We helped to predefine who and how. So we already had some of these communities defined by race or geographic area. And then we thought about how can our campaigns be smaller but more iterative. And some of this adaptation work was really conducted with Elizabeth Towner and Brilliant Detroit through another project as we were moving into our CEAL work. So each of our communities for this community translation process gets a COVID-19 101 presentation, epidemiologic data, really understanding what's going on with COVID-19 more broadly, and some information about effective communication strategies. They get technology troubleshooting before they jump into these virtual meetings, and then some information about their facilitators and the other participants in the process. These community members come into the rapid community translation for this process of 6 to 8 meetings. They get a mini expert talk, the current evidence on COVID-19 vaccination and local data, what the community needs to know, what messages. So they're really focusing on the messages they need to tell their community. And some of our communities sort of brainstormed potential products up front and then selected those as they moved through the process. We had a graphic designer engaged in all the meetings. So they're really hearing what the community is saying and trying to bring that to life throughout the process. They have homework between meetings. So really thinking about how can we move the process quickly. We have a phenomenon we call wandering in the desert, where communities can sometimes get stuck and talk in circles. And we really worked with our facilitators to help move groups forward and not allow as much of that wandering. And to use homework and online virtual discussions to maintain momentum for those groups. Some of the key adaptations we made to community translation were to change that name. A number of our communities told us, we don't really like this being called a boot camp, and that had connotations that didn't feel appropriate for their communities. We brought in community member co-facilitators, so we started to train up community members and think about that capacity building for them. Changing communication modalities, so this had often been a process that was done in person with email communication, and some of our groups even moved to like WhatsApp as their primary mode of communication. And language justice. So I'm going to give a case example real quick about our Somali community, but many of our community members were not literate. And so really thinking about different ways to engage with this community. So just to reorient you, we're Northeast Colorado and primarily Somali Black immigrant community. So this is really unique. It's a community we hadn't worked as closely with in the past. So we had to build that trust up from the ground. Our Somali community connector was amazing, Mahad. He really expertly navigated the social landscape there and guided our team to make some of those adaptations I just talked about so that community members could fully participate in the project. Like I said, we had challenges with both language and literacy. Interpretation was brought in for our first round of community translation and turned out just not to be the best way to engage with this community. And so we moved to the group functioning fully in Somali with Somali facilitators for our second round. Thinking about our community and group norms, social structures, and sociopolitical considerations. And then again, the survey process, the community translation really revealed that having that community connector and credible, trusted data collectors were difficult to find, but essential to the process. And that community members really expressed that the information they learned was information they felt they could trust, in part because of those community partnerships that led the way. What they came up with was sort of a three-part intervention. So the first were flyers and posters that were created for community members and business owners to share. So again, thinking about who are those trusted community members. A PowerPoint presentation that could be shared by trusted members of the community in events. So not something you would send out to somebody, but they actually hosted events where people shared the information. And then they are working on an informational Somali language video that can be shared via social media. So what we have learned so far is that bootcamp translation could become community translation and be adapted to really address COVID-19 vaccine hesitancy in communities experiencing disparities. But we are still working on assessing effectiveness and some of our implementation of this. Our community connectors and other gatekeepers can really engage our community members. They are essential to the work that we are doing. And that, again, hiring and training community members to serve as our data collectors, put that data collection in the hands of trusted community members and really made it possible for us to recruit 1,000 community members in these communities in a pretty quick timeline. Our community translation process really supported the formation of critical partnerships between our university and members of our community and building those bridges. It increased the local evidence or relevance of this evidence-based information we were trying to share with communities and delivered that through multiple community channels. We learned that tailoring to our community culture and concern is essential, and doing that differently within each of the communities that we're working with. And we learned along the way that we, as university partners, have to be investing in capacity building that support our partnerships so that we can continue to work with these communities to address disparities, not just around COVID-19, but really to advance health equity. And I think that really aligns again with what Dr. Stinson said at the beginning, that this is not just about COVID-19, but this is about being able to work with communities long into the future. And just an acknowledgement that this work is really funded by NHLBI and NIMHD, and we are incredibly grateful for their support of the work that we've been doing.
Thank you, Sarah. That concludes our plenary this morning, but I do want to plug again the roundtable, which is on the 3rd floor in the Beckler room, 302. So if you want to keep this conversation going, please join the speakers there. We have 2 community partners that also will be joining for that roundtable. So enjoy the rest of your conference. Thank you.